Hi everyone, and welcome back to the HP Leader podcast. And today we are presenting a whole day on COVID-19 cardio-respiratory rehab, and I'm delighted to start the second session with Laura. She's going to share her slides and introduce herself in a moment, but just a reminder that if you are watching this live, please put any questions in the YouTube chat box. You do have to be signed in for that, or on Twitter, or DM me. That's the best way. So over to you, Laura.
Thank you. Hi everyone. My name's Laura. I'm a respiratory physio working in Hackney. I'm just going to share my slides. Brilliant. I hope that everyone can see that. So yeah, I'm the respiratory lead at the Homerton Hospital in Hackney, which is a hospital in London. I also support by co-chairing the London Pulmonary Rehab Network and work with the BTS's Pulmonary Rehab Special Advisory Group. So thank you for inviting me to talk today, Rachel. I'm here to discuss some of the considerations that we might need to think about in the moment for delivering pulmonary rehab in this current time, but also just including some of the considerations for delivering post-COVID rehab if services are choosing to do so. Obviously, this will differ depending on where you are, both in the UK and internationally, but these are some of my thoughts. So the plan today is to give a bit of overview of the guidance. This is UK guidance, some practical considerations that you might want to think about some of the assessments required. So I'm not going to talk so much about the actual assessment that you might do when thinking about enrolling someone on pulmonary rehab, because that's coming next. But I'm going to think very much about the assessments that you might need to have in place before you start running your assessment clinics or your groups. I'm going to talk about business continuity and then just some stuff on post-COVID rehabilitation. So pulmonary rehab, we know it's a gold standard care for people living with chronic lung disease. We know it's a vital treatment and it's a key priority in the UK of the long-term plan. Provision during the pandemic for everyone has been very challenging. We've had to think about the risk of delivery versus benefit. We know there are a huge amount of benefits to pulmonary rehab, but obviously that's got to be taken into consideration when thinking about services as a whole, across a whole trust and hospitals. There's been an incredible amount of innovation, and this is fantastic. Some of the stuff that we're seeing online that's being shared is just absolutely brilliant. But we need to know how these new hybrid and adaptive models compare to what we were delivering before. However, I'm sure at the moment we all agree something for our patients is better than nothing. So the British Thoracic Society produced some pulmonary rehab business as usual guidance back in July 2020. So they said that the rehabilitation services should resume as early as is safe and feasible to do so. They acknowledged that programmes would have to adapt in order to do this, but they highlighted that in adapting the programmes, the assessment part of the programme was absolutely vital, because this ensures that safety is patients are deemed safe to exercise, and it also allows for effective exercise prescription. But they did say, as a minimum, we should be providing our patients with some self-management advice and some advice on physical activity. However, this self-management advice and physical activity does not replace the gold standard supervised PR. So what do we have to think about at the moment if we're wanting to restart services? I know many services in the UK have restarted, but it might be that we're changing the way that we want to deliver. We've got to change the way in how we deliver our rehab because of restrictions or because of risks to the workforce and capacity. So we do have to consider what are the current restrictions for the area that you live in or work in. What are they and how would that impact on the delivery? You need to think about what the demand is for the service. We have seen a drop in referrals to pulmonary rehab for multiple reasons, but they are starting to pick up again, and they will continue to pick up and I'm sure increase over time because of the effect of social isolation or being locked down, but also and deconditioning that we have seen, but also that within the UK in primary care, CPD and asthma reviews are starting to happen again. And also we've got this new cohort of patients who have been hospitalised following their COVID-19 virus. So what is the demand and how will that influence the capacity of the service and the mode of delivery? What are the appropriate, what are the available estates? Definitely within London, we've seen a lot of services have reported that their estates, they've lost access to their estates. I think on Twitter we've seen pictures, you know, of gyms being filled with or used as storage or offices because of social distancing. You know, what is the appropriate state available? And we need to fight for that appropriate available space as well. And what, you know, what do you need to run your clinics and your groups? And are these within the infection control guidance that you have locally, but also nationally? And does this essentially provide privacy and dignity for everybody involved? In terms of also thinking about the mode of delivery, what's the most appropriate for the capacity, and for your local demographic, thinking about, you know, people in terms of digital exclusion. We've got quite a socially deprived population in City and Hackney, and access to technology has definitely been an issue for us in delivering our rehab. So we've had to think about that in terms of what's the most appropriate mode of delivery for our population, and also in line with the space that we have available. What technology do you require? Thinking about, you know, do you have that available screens? It's very difficult, I'm sure, to do virtual groups on tiny screens. We are using laptops in our service, but obviously, you know, ideally we'd want a much bigger screen so we could see clearly our patients. But you're also thinking about things like headsets, speakers, camera, the equipment needed to provide the intervention, but also the equipment that patients might need in order to be part or take part in our POMI rehab groups. On top of that, I think we have found definitely that staff saying digital confidence is definitely being tested, and therefore there may be a training need there. What is that training need? We have to think about that for all of us before running our groups. The other thing is that once I've decided, or we've decided where we want to run a group and how we're going to run it, who do we need to talk to? What managers? Our trust managers, our service managers, our stakeholders as well, explaining that the way that we deliver rehab is affected, but also that we are able to offer something, what that is. Need to think about comms. I think updating websites is really important because it really sets expectations for both patients and also for referrers. And thinking about what patient information we might be needing to change or provide in order to engage them with our rehab service. And also on comms, it's thinking about when you're able to accept referrals and making sure that referrers are aware of that because of the drop in referrals that we have seen. Health inequalities impact is really important, assessment is really important, because we know that there are a lot of health inequalities that exist in the delivery of healthcare. And unfortunately, the pandemic has increased some of those. For others, it's been an opportunity, but for some areas of society, it has increased the access to a particular services, and that's particularly with digital exclusion. So we do need to think about that. And then if you are delivering any sort of face-to-face, or even if you're using a shared space for a virtual class, what's the impact on the other services? We've definitely had to fight for space locally in Hackney to deliver our virtual groups. And sometimes delivery of virtual stuff isn't considered in space allocation as is face-to-face delivery. So risk assessments are really important, and I'm sure many of you have done these for your POMI rehab programs. You need to think about your local risk policy procedures. But our risk assessments, and this probably has come up already today, also needs to cover all the modes of delivery, all the venues that you are going to be delivering your rehab in. But it is a continuous process. We do have to continually reassess the risk as things change. And what are we doing? We are rating all the likely hazards that could occur versus the consequences of them if they did occur. And these are going to include things like infection control, guidelines and procedures, such as PPE, social distancing, patient flow, if you're using or you're delivering anything face-to-face, and I'm sure that will be discussed later as well when considering face-to-face rehabilitation. You need to think about your emergency procedures, so things like falls, what happens if a patient falls, if you're delivering a remote class or remote assessment, what happens if the patient becomes more symptomatic during that class or during the assessment. And we also have to think about if someone collapses or has a cardiac arrest, how are we going to be able to deliver CPR? There are new guidance around delivery of CPR in terms of the required PPE, so you need to check your trust procedures, but also the Resus Council provide will provide guidelines on this as well. But what happens if someone's at home and they collapse and you're unsure if they've having a cardiac arrest, how are you going to get help to them quickly? So that also needs to be considered. Considering ventilation, air changes are really important, and this will differ depending on the venue that you're providing your rehab in. Clinic, if you've got somewhere that's naturally ventilated, that's okay. Generally, the ventilation is good in a naturally ventilated room. The air changes occur naturally. But if you've got an air-conditioned room, you need to check how many changes there are per hour, because this will affect the number of people you can get through in a clinic and the length of time that you need to have between each appointment. But also in terms of a shared space, if it's got air conditioning, you need to think about who is coming in after you and how long you need between your two groups. And this is particularly important when thinking about the use of other external venues. I mean, they will have their own risk assessments, their COVID safe plans in place, but they may also ask you for yours. And I know with our leisure centres, they've asked us, as we're considering at the moment, about return to face-to-face for our COVID safe plan. So I've put in something around business continuity, because I think this is really key, and every service should have a business continuity assessment. We are found this now in London, that we've had a lot of services that are at risk of having staff redeployed, and obviously having set up this new adapted and hybrid model, we need to think about how that can be continued in light of current and future surges. So it's thinking about the risk versus the benefit of not delivering it. I mean, we know, I'm sure anyone who delivers any form of rehabilitation knows the benefits to the patient and the benefits to the service, and the benefits, we've got to think about the benefits to the trust as well of not delivering, but also the benefits to the trust of delivering. We need to think about the minimum requirement. What could we deliver minimally? So this might be going back to that sort of self-management and physical advice that's within the British Thoracic Society recommendations. But how many staff do we need to do that? And we need to protect those staff from redeployment where possible. And then thinking about anything that we deliver, if we've started things like virtual groups or face-to-face groups, what happens if your staff are redeployed? Are these feasible and sustainable? What is your contingency plan for those? Thinking all of this in line with regional and national guidance. Nationally, we've been told by NHS England, as I'm sure other healthcare bodies have around the world, that we've got to continue delivering our elective and routine work. But we do have to think about what happens if suddenly we get guidance to shut down again, as we did in the first wave. And I've just said it's also good about considering that if you can't run your service, is this highlighted on a risk register? We've had to do that for our cardiac rehab service because space has become an issue and redeployment is a real risk. But I do think we need to highlight the risk to our managers and trust directors of if we're not delivering these services, what the longer term impact will be. I think if you do reduce your service to a minimum, think about the comms. It might sound quite attractive to those who fund our services at the moment that we can deliver this new innovative way, and that actually, you don't need venue space, but actually we need to say this is just the minimum level during the pandemic only. This innovation is absolutely fantastic and there's so much going on, but we need to understand its place in a pre-COVID service delivery. So other assessments to consider, and I'm sure these will be mentioned throughout the day. So thinking about pre-assessment screening procedure of anybody that's coming into a venue, whether it's for a clinic or whether it's for face-to-face rehab, and also what happens if you go to someone's home. Safety precaution checklist for any remote options, and the British Thoracic Society have produced one of these, and it's on the web link there. Also, as I said earlier, the health inequalities impact assessment. You might want to think about your trust or team remote working policy and procedures. You may, as a team, want to think about how you may have or need to have a remote working policy within your team. You would want to update your standing operating policy or procedures based on the new way of working, or have it put in as an appendix maybe in your current operating policy. Business continuity plan, as I've spoken about. Staff COVID risk assessments, this is really important. These are ongoing and should be continual. Thinking about anyone that's vulnerable. If you are starting to deliver face-to-face work, is that feasible? Is that possible based on your staff risk? And then also, because we are doing a lot more remotely, it's really important that we are considering where these are being delivered and how staff are set up at their desk in their workplace. So as I've said, this is about the pre-screening. So thinking about anyone that's coming in and your procedure in terms of pre-screening. So can this pre-screening be done verbally? Can it be done electronically via text or a questionnaire? I know some services have actually created a form in which they send out to patients before their clinic or before their group to complete, and I think that's a really useful way to do it, but obviously that's not, everyone will not be able to manage that, so we might need to think about who needs to have a call. So we do this in Hackney. We do it on the day that we're booking the appointment. We screen for any COVID symptoms at point of booking an appointment, and we discuss the appointment procedure so patients know what to expect. We also do it on the day before or the morning of the appointment. We do a COVID screen, and we discuss again the risks and concerns they may have with coming in for their assessment. And we discuss the appointment screening as they arrive. And I think this is really important so patients know what to expect on the day, because we have had patients turn up and refuse to be screened, and we've not been able then to deliver their assessment. And then when they arrive at the venue, their symptom screen, and also we would check their temperature, and we're looking for a temperature below 37.8 degrees. So the last few slides I'm going to talk about are just on targeted and safe rehabilitation adapted pulmonary rehabilitation for those anyone that's post-COVID. The British Thoracic Society suggests that this is targeted and safe, and rehabilitation could be supported as part of a patient's recovery after their COVID infection, but this should be delivered 6 to 8 weeks post-infection. I think it's worth considering, and I'm sure this has come up in the fatigue talk, that recovery is not linear for everybody post-COVID, and for some it will be non-linear, and they will have this relapse and remitting nature. And I think we do really have to think about this when considering who is appropriate for pulmonary rehab, if we're going to accept them into our programme, is that the most suitable care pathway for them. It's a multi-system condition, COVID-19, as we all know, and it's therefore requires a large multidisciplinary workforce in order to manage it, particularly the complex patients that have overlap of multiple symptoms. We are still learning. There's lots of emerging evidence of where pulmonary rehab's place in the post-COVID recovery is. So it's an iterative process, and one that will be continuing. However, if you are going to be accepting patients following COVID-19 into pulmonary rehab, you do need to think about your inclusion criteria, and this is the inclusion and exclusion criteria from the British Thoracic Society guidance. So the patient should have ongoing rehabilitation needs and goals. We haven't, obviously isn't on there a confirmed diagnosis of COVID-19, because not everyone will have a confirmed, as testing wasn't available. So it's confirmed or suspected COVID-19, previous COVID-19. Service dependent, so who are you going to accept? Would this be everybody, or is this just people who've got a new respiratory condition? And I think, you know, we do really have to think about the impact on the rest of the service and delivery of the programme to our non-COVID patients, our existing patients, those where the evidence is, or those that best fit the evidence, so our chronic disease patients. Exclusion criteria. So the British Thoracic Society suggests that rehabilitation pulmonary rehab should not be for those who best fit an alternative care pathway. So this might be cardiovascular or cardiology, this might be neurology, renal, it might be, you know, requires an MDT inpatient rehab. It's not beneficial for anyone who cannot manage the intensity of the programme. So maybe thinking about our more frailer patients, those towards the end of life. And it shouldn't be for anybody with an active COVID infection. So I would recommend that you use a checklist, and again, the British Thoracic Society have a checklist that is available for all to access. Also think about a post-COVID screening tool for symptoms. There are a number of screening tools available. I think the recent guideline has, NHS England has talked about the Yorkshire tool, but there are others available as well. And this is really so that you get an idea of all symptoms. So breathlessness, fatigue, as I've said, it really is one of the symptoms that is reported by people, one of the main symptoms, as we've heard earlier this morning. Mental health, function and cognitive screen. The complications that we do have to consider cardiovascularly and would mean that someone isn't appropriate for rehab. So myocarditis, it's said that we should not be exercising patients within 6 months of a reported myocarditis. And for deep vein thrombosis and so PE, we should not be cardiopulmonary exercise testing anyone for at least 4 weeks once they've been commenced on anticoagulation therapy. So in conclusion, and I said this is as an overview, pulmonary rehab service continuity is vital during the pandemic, and services should resume when it's safe and feasible to do so. And we need to have a think about the assessments that we need to put in place in order to ensure that something is safe. Business continuity is vital. However, delivering something is better than delivering nothing. And if this is self-management, we need to make sure that this does not replace the gold standard PR. Adaptive models may be a model for those recovering, or adaptive PR may be a model for those recovering from COVID-19, but we're still learning. However, the provision of this should not be at the detriment to the evidence-based pulmonary rehab that we've been delivering for many, many years. Thank you very much. I will take any questions.
Wow, thank you very much. That was incredible, and thanks so much for being bang on time. We have a few questions popping up in the chat. A couple of them people have commented on YouTube. So how do we find out what kind of rehab people want? So if you think about your classic patient that would be referred to pulmonary rehab, now will have options we've never had before. And I think this really opens up the wider conversation, doesn't it, Laura? I mean, you are an expert in this field. Like, you know, when we talk about guidelines, you're partly because of them. So massive thanks for all your work in this field. But how do we know what patients want? And just combining it with a couple of other questions, is this the future?
Yeah, it's a really good question. I think in terms of finding out what patients want, I think we're learning still what people want. And I think interestingly, from the cohorts that we've run locally, they love the face-to-face. They said that will be great in the summer, but the virtual option might be really good through the winter when they don't want to be going out because they're worried about catching viruses and flu and obviously now COVID. So I think you know, we'll learn more about what patients want, but we need to ask them, and that's where that comes into the assessment and explain the options. If someone wants to choose virtual but they just don't feel they're digitally confident, then we need to work with that patient, you know. And I think there will be roles for sort of digital champions and you know, going out and working with people in the home. And I think that's where, if you can offer some home rehab, it's quite nice, because you can go and do that assessment and maybe set them up on their virtual program, but that's not achievable everywhere. So I think we're learning. I think we need to and I know lots of services are doing this now, going back out to patients and sort of doing focus groups and understanding what the benefits of this new delivery were, but also what the challenges were and the barriers, and sort of asking, you know, where do you think this has a place? Because patients are key to this and this development that we're doing at the moment. And in terms of, is this the future? We need evidence. I think it's been fantastic, the amount of innovation that's occurring. I think we should be really proud as a community of how we've met the challenge of delivering rehab, and that's not just pulmonary rehab, that's rehab in general. I think we've fought really hard to keep rehab going for our patients because we see the benefit of it, and that's just fantastic. But we do need to compare some of the modes of delivery to the face-to-face options to say they are comparable. However, you know, having said that we do not reach everyone, and we do have poor uptake rates, and we do have, you know, poor completion rates. So I think we need a menu of choice, but we need to understand and be able to say to people, this is, you know, this will give you these outcomes, this is the, you know, comparable to the gold standard, where we know we get, you know, improvements in multiple things. But if you don't feel you can deliver that, or you don't feel you want to attend that, then we've got these other options for you. But it will depend on the area that you work in as well. You know, I think there are different barriers based on, you know, where we live in the country, internationally. You know, travel has been an issue in many places. In London, that's not necessarily always an issue, or bigger cities. You know, that's where we need to understand what the local differences are as well. But it is great. We've got choice. That's great.
Yeah, and I think we're going to hear today about some alternative rehabilitation models, and this was happening before COVID. You mentioned the uptake of pulmonary rehab and cardiac rehab being the most evidence-based intervention If we think about quality of life, we think about qualities and cost effectiveness, there's no denying that, but there was a problem with uptake. So absolutely. Actually, this menu-based approach that you've just touched on is the non-PR expert here. Never have I specialised in this field, but it is for me, it's a really interesting concept because it combines the post-intensive care rehab, it combines respiratory rehabilitation when people don't fit a diagnostic criteria to enter a pathway. So maybe COVID, like you said, has accelerated that. Maybe COVID has got us thinking. I mentioned in the first section of the day about how cardiac and pulmonary rehab have come together like I've never seen before, like on the manager side of it. And I really love that, because sharing the risk assessment, sharing the ideas. So I love that that's potentially part of the future, but like you said, protecting that evidence base, protecting the PR and the CR rehab, because we should. Now,
absolutely.
There's a couple of questions coming through about patients. So you have a COPD patient, a classic patient that is referred for pulmonary rehab that should enter a pathway, but they've also had COVID. So they're fatigued, but they need their PR. And we know with PR, the interventional point is, is crucial in terms of the effect. So what do you advise for patients who are coming into the pathway but have like long COVID fatigue type symptoms? We've just heard fabulous talk from the ME physios that say rest. But at what point or what kind of things would you be thinking about?
I think that's a really good question, and I think it's really challenging for services as well at the moment when you're having to think about, you know that you've got this evidence-based treatment for one condition, but is that the primary problem at the moment? And I think that's where the holistic assessment is really important. I think we will see, there are obviously some post-COVID rehabilitation programs that have been developed, and I think we will see more of those, but obviously funding is a barrier at the moment. I think you have, again, that comprehensive assessment is really important, and I think we have to think about, yes, we've got this gold standard intervention for their COPD, but as the ME talk earlier would have, I'm sure, said, we've got to think, if we deliver that, is it going to be detrimental to their COVID recovery? Rest is important, pacing is important. So I think it depends on the patient, and I think it will, we've talked a lot about within post-COVID rehab assessments for non-rest patients, like how do we deliver those without impacting on their fatigue? We don't want to make someone more fatigued and then send them into a relapse because we're trying to deliver an intervention for another condition that they have. It might be that you start very functionally, and it might be actually coming into a group or a virtual group isn't the way forward. You actually have to start with functional rehab, and eventually once they are on a more linear, hopefully, recovery pathway, and you can say, well, actually are getting better, and you've got that time point, then you start to think about pulmonary rehab. If you are going to deliver pulmonary rehab, or they really are keen, then you need to explain to them the risks of doing so to their fatigue and other symptoms, but also think about the intensity at which you're prescribing that exercise. So it's really hard to put a standard rule on this, or a standard recommendation, because actually it's going to be completely patient dependent, and we will very much be guided by the patient. So we need to work out whether or not it's the COVID has exacerbated the pre-existing condition as well, or whether this is COVID recovery. So there are lots of variables that need to be considered. I think we are learning, and I think more guidance will come out on this.
Yeah, and I think that's where the assessment part's really important, Absolutely. Isn't it? Which we'll be talking about in more detail, but it's assessment by, a clinical expert, if you like. So, this is why, whether it be a physio nurse approach, and you've mentioned functional rehab and vocational rehab in COVID times, and there is never a more important time for this, and it's recognizing the differences, and this is when our OT colleagues come in, and so Absolutely. I think you absolutely hit the nail on the head there.
We have to recognise our limitations. Like, we need to access that MDT. This is an MDT approach, as all rehab is. But I think, like you said, it's been accelerated by COVID, that we've all come together, and that's fantastic. And I hope that continues, because it's just been brilliant.
Absolutely. So there's some questions coming through that we'll definitely cover in the other sections around videos for assessment and screening tools, etc. But Laura, thank you so much. Okay. Bang on time. And our next speaker's in the room. So
brilliant.
Laura's accessible on Twitter. Our Twitter handles will be all over. If you want to ask her any questions, please do. Thank you so much, Laura.
A good rest of the day, everyone. Thank you. Bye-bye.
So I am delighted our next speaker is here, Karen. I am very fortunate, disclaimer here, that I work with Karen. And she and the team have done a phenomenal job in COVID times, never stopped delivering rehab of some description. So Karen, I'm going to let you share your slides and introduce yourself. And we're really looking forward to your talk. There's lots of questions coming through already that I'm sure you'll be able to answer.
Oh, I hope so. Right, let me find it.
This is always the most nerve-wracking bit, seeing if you can share.
There we go. Is that working?
Perfect. Thank you.
Lovely. Let me make it. Oh, give it a minute. Hopefully. Is that working?
It's just a bit slow by the looks of it. It doesn't want to do slideshow.
Sorry,
okay.
My internet, my kids are doing dance lessons downstairs, so we're having to share the internet, so that might be the issue.
There you go.
There we go. So hello, I'm Karen Ingram. I'm a highly specialist physio, and as Rachel just said, I'm working at Harefield Hospital in the pulmonary rehab department, and I've been asked to speak about face-to-face and virtual rehab assessments, kind of in current COVID world. And so I'm going to kind of go through face-to-face briefly. I think that's probably the assessments most people are more familiar with. And so I'm going to mainly focus on virtual assessments. And as there's not a gold standard out there, I will just sort of be talking through what we're doing in the hope that it might give you guys some ideas, or at least kind of encourage you in the sense that we're all doing similar things, and hopefully answer some questions that you might have. And because I'm pulmonary rehab, it will very much be from a pulmonary rehab point of view, but a lot of it would be similar for cardiac rehab as well. And as Rachel said, we are sharing risk assessments and infection control protocols and procedures and things. So there's a lot of crossover. So in the face-to-face, I'm going to sort of cover the benefits as to why you might try and choose to assess face-to-face if you can, and some of the considerations to think about. And then with the virtual, some of the screening you might want to do for patients, and the risks and the components to think of. But firstly, just to kind of say, well, we've got to assess our patients in order to provide pulmonary and cardiac rehab safely. And we've got to think about the safety of our patients and staff. And with that comes this need to balance the risk of COVID transmission with clinically vulnerable patients, and balancing that against the negative effect of not delivering any care for them. And certainly I know some of you will have come across your patients who during the first lockdown had no intervention whatsoever and have suffered as a result. So we've got to make sure that we can continue delivering care throughout this second surge. So face-to-face assessments, what we all traditionally did without even sort of often thinking of other options, are the gold standard assessment if you can. And I know not all venues are back open and it's not always possible, but it does allow us to do a good aerobic and resistance assessment with our patients. We can get accurate measures, of things like their height, their weight, their blood pressure and things that, doing it virtually, we may not be able to get. It allows us to do field walking tests like the incremental shuttle walk test or the 6-minute walk test, or 1 rep max strength assessment, so that we can actually then prescribe accurate and good standardized prescriptions for our patients. It means we can assess their balance maybe more safely and more accurately, and check about safety, looking at their gait, looking at kind of some of the aids they may or may not need to use. We're more easily able to pick up patients that desaturate on exercise, which again might be more tricky virtually. And importantly, because you don't need the tech, you don't need computers and cameras and everything else, it does mean we can offer an equity of care, really, where everyone can receive the same care no matter what either skills they have or technology they have available to them. So it's the ideal if it's possible. But there are things that we do need to consider. And I know Laura's already touched on some of this, so apologies for any repetition. But it's so important that before their appointment, we do a COVID-19 screen, and we do ours on the telephone within 24 hours of their appointment to make sure that they haven't got any signs or symptoms suggested of COVID. You have to make sure you've done really thorough risk assessments, and that includes the environment that you're doing your clinics in. So have you got enough space, and if so, how many people can you have in at any one time, maintaining that social distance, what kind of cleaning procedures you need to have in place, the ventilation, so just simple things like the windows open and things like that to make it a safer environment for our patients. And infection control measures, so what PPE your staff need to wear. So we are wearing our visors, our surgical face masks, aprons, gloves, but it may be different in different areas. The use of hand sanitizer and having it readily available, surgical face masks for the patients themselves, and all those kind of issues really need to be thought of and planned for to make sure that your clinics are safe. And so this does need to be kind of documented in your standard operating procedures so that all the team and all the staff know exactly the safe way and the correct way to run these clinics. As part of our risk assessment, we ask patients to attend by themselves unless it's absolutely necessary for them to have a carer, because of course if they come with family or friends, we're then putting family and friends at potential risk when they don't need to be. Spreading out appointment times to make sure that you reduce contact with other patients so that they're not in the same place at the same time, and things like having a one-way system so that they come in one way and go out another way, again to try and avoid that contact. And then when the patient actually arrives, things to do to kind of again reduce risk and to keep our patients as safe as possible, doing a temperature check for them to make sure that they haven't got a temperature, again giving them a surgical face mask, making sure they don't have any symptoms that haven't, that might have developed since you last did the screening, and that they're using good hand hygiene. You're maintaining your 2 meter social distance, and that you're keeping the appointment duration to a minimum. So again, the patient isn't there longer than they need to be. And I think that's probably my summary of kind of the main considerations for when you're doing your face-to-face assessment. What I've not gone into is kind of what your face-to-face assessment should include, because I'm hoping that any of you that are doing Pulmonary Rehab already know that and have been doing that for a while now. But what we do include in ours, so that it's a nice short appointment, we do their OBS, we do a shuttle walk, we do a balance test, and we do the short physical performance battery, and then we do a strength test, and we do a 1 rep max knee extension. And then before the patient leaves, we try and teach and demonstrate or practice their home exercise programs, or the unsupervised exercises that they can then do at home. So moving on to virtual assessments, and this is probably a lot more new ground for most of us. Again, it's very important for safety that we do screen our patients. If we're not going to be seeing them face to face, we need to make sure we've got a good clinical history. And so as well as our full past medical history that we do with patients, we've adapted this Easy Tools. So the Easy Tools are an online screening, and we've just pulled from that 6 questions to give us a really quick assessment as to whether patients have any clear medical issues that we need to address before their assessment. So do they have pains, tightness or pressure in their chest? Are they getting dizzy and lightheaded? Have they got high blood pressure? Do they have pain, stiffness or swelling? do they have falls or balance issues, and any concerns that they have about starting an exercise program. And we've found that with that sort of really quick screen, it highlights any issues very easily. And then, because we want to know for our patients that they are safe to exercise, things like high blood pressure that you may not know, or you may not be able to tell, or the patient may not know. So we put in place a sort of an equipment delivery. So either for patients that didn't live too far away, we did sort of a doorstep drop off where we would give them a pulse oximeter on loan, and we would check their blood pressure. For those that lived further afield, we sent it in the post. And we also gave them the Borg breathlessness scale in nice large print, and the perceived exertion scale, so that they had those that they could then use for their assessment and for their classes, so that we could get that feedback when they were doing their exercises or assessments. As Laura said, risk assessments, and they're not everyone's favourite thing to do, but really important to do. And so again, some of the things that are included in ours, making sure that the patient consents, not just to the assessment, but it's actually consenting to and making sure they understand the risk that they might be doing a test that could get them very breathless, that could increase their heart rate, blood pressure, and they will be remote from us, so we won't be there on hand. Their consent that they're happy to have part of their house on view, consent that they're happy to use their device, and all those sorts of things. So a really nice informed consent from the patient. For the assessment, we insist that there's an able-bodied person in the house with them. For in case of emergency, that there is somebody who would either be able to talk to us on the phone, or tell us, maybe what's happened if the patient's just disappeared off the screen, or could ring for an ambulance, or whatever might be needed. To make sure that their devices are charged and working. That's quite a definite that needs to happen for the virtual assessment to be successful. And as well as having a, say, tablet, laptop, phone for the assessment, to have another phone or mobile available, so that if you lose connection, you can use that other phone for emergency use. Patients have to have their inhalers or GTN sprays to hand, have a drink, a sturdy chair. We do a 1-minute sit-stand test, which I'll come on to in a minute. Their pulse oximeter ready, trip hazards out the way, so no rugs, no pets, no grandchildren or whatever running around at their feet, and that they're in appropriate clothing. And that's just, again, some of the kind of key summary things to consider. So once we've done all of the screening and the consent and everything else, and we come on to the virtual assessment, the first thing we do is a balance screen, really, so that we hopefully are happy that the patient is safe enough to continue on to another exercise test. And we do the single leg stance test. And I couldn't find a better picture, so apologies. But there's this journal by Rachel M. et al. In 2020 to show that people with COPD have balance impairment and an increased risk of falls. So we know that our population are at risk of falls. And the ATS ERS guidelines do recommend that you include balance as an outcome assessment in pulmonary rehab. And we chose the single leg stance because it has excellent reliability in COPD patients as well as in community dwelling older adults. So it really fits our cohort of patients. And there are, it's not the only option. So there is the brief test as well that can be used for balance screening. But this we thought was quite simple and quite easy to do on camera, because it is literally, as long as your patient's near a wall, getting them to stand with their hands on their hips, and then they have to lift one leg so it's not touching the other leg, the floor, the wall or anything, and balance for as long as they can. And you do the best of 3 attempts, and if it's under 5 seconds, that shows that they have a high risk of falls. Over 5 seconds, then you've got medium and low risk. If the patient does over 60 seconds on their first attempt, you don't have to make them do it 3 times. But yeah, there's again a nice protocol for So once they've hopefully passed their balance screening test, we are doing a 1 minute sit to stand test with them as a test of their exercise capacity. It's been shown to be suitable for use in clinical practice as well as research settings when you can't do the traditional tests like your shuttle walk or your 6 minute walk test. And it is simple and it's a sensitive test. And there is a study to suggest that a minimal important difference of 3 stands represents a good target to assessing whether your patient has gained anything from their pulmonary rehab course. So again, we make sure that a chair is positioned up against a wall, and again, it's useful to have this able-bodied person around in the house so they can help position the camera so that you can see as much of the patient as possible. It's not much use just being able to see head and shoulders. And hands on their hips, and they literally have to stand up straight and sit back down as many times as they can in 1 minute. And we make them wear their pulse oximeter on their finger for that, so we can have a look at their oxygen levels and their heart rate before and after the 1 minute sit to stand. So it is one of the better exercises that you can do in front of a camera. The main problem with it is that, you know, if someone does 20 stands, you can't prescribe exercise from that measure. So it's good to assess for safety and it's good as an outcome measure, but it's not ideal for prescribing exercise from. And if you are doing virtual assessments, hopefully you all have an emergency protocol in place so that if your patient does become unwell or does start, you know, developing serious symptoms or, you know, disappears off your screen, that you know exactly what to do and how to handle that situation. So yeah, this is just our algorithm that you can briefly see, but it's just to give an example really. So in summary, just as you all know, it's really important to actually have a safe and effective assessment for our patients to make sure they're safe, to be able to prescribe exercise, to make sure that you're picking up all the things you need to. But you must make sure that you've got all your risk assessments and your standard operating procedures and screening tools and everything else in place so that it is safe and that you can run a nice standardized assessment pre and post rehab. Thank you. That's my kind of overview, if you like, of face-to-face and virtual assessments.
Thanks, Karen. Well, wow. I don't even know where to start with the questions. So there's lots coming through about the 30-second sit to stand test. So the question is it recommended and should it be used as a validated test in this situation? I think you kind of covered that, but do you want to just maybe say why?
Yeah, so I've stopped sharing my screen. I was going to bring it back up again. Yeah, so it is sensitive and it is reliable. In COPD, to my knowledge, it hasn't been validated in other respiratory diseases or cardiac diseases. So it definitely is a good tool. But as I sort of alluded to, really, it's good to assess pre and post, so you can get sort of an outcome measure of any difference. And it is good for being able to check safety for desaturation or heart rate. But what you can't do is prescribe exercise from it. And that's its major downfall, really, is that, you know, it can't be used like the shuttle walk or like the 6 minute walk test to be able to kind of then set prescriptions for patients. That's kind of example.
Okay, thank you. That makes complete sense. There was a question at the very beginning about, and I think you covered it beautifully, about having family on able-bodied other in the room.
Yeah.
How do you try and get families or households to participate in a positive way, in a helpful way during some of the virtual assessment?
So in some cases it's very easy, a husband or a wife, or it is just there on hand, and to be honest, most of them are quite interested to see what the assessment's like, so they want to be there and they want to kind of watch, if you like. So most of the time it's not too much of an issue. But yeah, there are situations where it takes more careful planning, and it's been, depending on what stage of lockdown, it isn't always possible if patients live on their own. And so we do have some patients that we haven't been able to do the virtual assessments on, which is why we really wanted to push to restart our face-to-face assessments. But even if we couldn't do that, some of our patients we just gave self-management and physical activity advice to. But yeah, for patients that you can get an able-bodied person, it is just at the start of the assessment explaining that it'd be really helpful if they can help position the chair against a wall, if they can, manipulate the camera so that you can see the full body and those sorts of things. And it's just having that communication, really. We don't have a sort of strict instruction manual for the able-bodied person. This is what you have to do X, Y, Z. But it's just kind of talking it through as you go.
Thank you. Lots of questions about the one repetition movement. What resistive equipment do you use, and how do you get around decontamination?
Oh, this is the one rep max. So in our face-to-face assessment.
Yeah.
So we've got a gym at the hospital, which is where we're doing our face-to-face assessments, and we have a knee extension machine in there. And infection control have said that as long as we wipe down the machine entirely after use with the Clinell wipes, which are known to kind of kill off pretty much everything, then it's okay to do our normal assessments, give it a good wipe down, and then it's usually half an hour because we've got staggered appointments before the next person would be using it. Yeah.
Okay, I'll stick to another question about the SLS balance test. If they can't do it without support, can they still do virtual rehab?
So no, and it's really tricky. But if somebody is, if someone is unable to do a 5-second single leg stance, then we've made the decision that they are at high risk of falls, and so we've said they wouldn't be safe for the virtual rehab. Now, I know there are people that will say to me they can do seated stuff, they can do, quite a lot from a chair, but we decided that because we have the other option of face-to-face assessments that we can offer those patients, that we felt happier to do that. So for patients in our cohort, if they are at high risk of falls, then we don't carry on with the virtual assessment. We would then bring them in for a face-to-face assessment.
So you've just kind of answered the next question from Helen. Are you keeping them on a waiting list for face-to-face rehab, or are you redirecting them into another rehab pathway? So I think you've kind of answered that, but would your default be to automatically always go face-to-face because we can offer that?
Yeah, so we've got the benefit of being able to offer face-to-face rehab at the moment. If we go into another complete full lockdown, then we would probably have to review it again. But at the moment, we're able to offer the face-to-face. Yeah.
And I think it's really important point, because technically we are in a lockdown, national lockdown at the minute, even though it very much doesn't feel like that. But we are continuing to offer both the face-to-face and virtual options because of the risk management, because of the infection control guidelines and assessments that we do.
And the main difference with this lockdown is that the government are encouraging people to go to their healthcare appointments. And we know that our patients with long-term illnesses are exempt from an exempt group and can continue their rehab.
Yeah, and there's lots of comments around the questionnaires and things, and you did mention in your talks, or it might have been before you mentioned this, that you send as much information as you can beforehand, including screening questionnaires, so when the patients come to face-to-face and it's in a staged fashion for social distancing, etc., as much as possible is being done remotely. Does that work with the population?
Yes, I wasn't, because I think there's another talk on face-to-face classes and rehab coming up, so I didn't go into the kind of rehab side of things. But yes, we basically give for our classes patients a blank COVID screening questionnaire and ask them to fill it out on the morning of their class, and they turn up and they bring it them, and if they haven't got it with them, we don't let them in until they filled out another one. So
yeah, and I think that answers a couple of the questions about COVID-19 screening. So exactly, you have it's given information before, they then have a reminder or a check the day before, and then if they come, they're asked if they have any symptoms. So there's like a 3-stage net. You can capture them through. So again, I think it's always thinking of the worst case scenario, isn't it? What if you haven't started any consultation and they're like coughing, or they say, oh yeah, I haven't been well this morning or yesterday. So it's really important to stress that you have this safety net, 3 different stages.
And that's why as well, I said about us staggering out appointments. If you've got patients like that, then you can get them out the way before anyone else is coming in. So yeah.
Thank you. And in terms of one final question, I think, just monitoring for the virtual assessments, things like blood pressure, how do you get around that?
So we've done the blood pressure check before the assessment. So that's where I said we've done the doorstep or that we've mailed it out. If their blood pressure is normal, then we don't recheck their blood pressure throughout the course unless they have their own machine at home. We can loan out our machines, but we sort of decided that as long as they have a normal blood pressure at the start, then we weren't going to monitor it every time, and we wouldn't do blood pressure for our patients every class normally. So we don't for our virtual either. If when we measure it at the start there's an issue or they've got really high blood pressure, then before they're allowed to enroll on the course, we would get that looked at and addressed.
Thank you. There is, and we'd almost predicted this, so there'd be a lot of requests for some of the emergency algorithms, protocols, etc. We are going to look to get either a Google online form or something for these documents. We, again, would normally put emails out, so we'd send them, but there is over 800 people registered for the session. So as you can imagine, I'm trying to have a workaround for something like that. So if everyone who's registered via the Eventbrite link, if I do get some stuff online in a Google document, I will let you all know. But yes, we can share those things because there's no point in reinventing the wheel, is there, Karen?
No, you just have to make sure that it is relevant for your area, because there will be differences. But yeah, as a kind of template or as a starting point, yeah, it would all be very similar, I should think.
Now, Philip has just come in with a comment about any talk of lateral flow tests for these patients at pre-assessment.
No, we're not, because we're not doing an aerosol generating procedure, and so infection control were happy with what we were doing. We've stopped doing our spirometry assessments before rehab, that we used to do, so that we're not doing anything that's aerosol generating, and then we can just hopefully use the normal system of good ventilation and everything else.
Yeah, there was a question about, do we check the room exchanges for the face-to-face? But again, like you said, Karen, we're observing social distancing at all time, regular hand washing, hand sanitizers, and using correct level PPE. So with all that in mind, and it's not an AGP, exercise testing in our trust, simple exercise, field exercise testing is not an AGP, but full kind of PFT spirometry is performed in a lab. So, and I'm sure we'll talk more about the precautions we take during actual face-to-face exercises. But, well, thank you for being bang on time. That is absolutely incredible. Now, Karen's not on social media yet, but we do work together, so I'm sure it's just a matter of time. But Heather, one of the other speakers, is, so I'm sure Heather's more than happy to field any online questions through or to myself. So thanks, Karen. That was amazing. Thanks for all your work and thanks for sharing everything. Now, we do have a 15-minute break. Like I said, we're dead on schedule. So we'll be coming back at 11:30 in 15 minutes time for our next speakers.